There we go. Now we are recording. I don't know how I did not press that button, but good job, Mr. McKeever. So like I said, rewinding a little bit, this is going to be talking about prosthetics and orthotics for your boards and looking at deviations. When I talked about prosthetics, the main thing with prosthetics we're going to be dealing with, again, if this sounds like I just repeated myself, I am repeating myself, is safety in wearing prosthetics and wear schedule. Those are going to be your pretty much primary questions on them. You may get a question that shows a picture of an AFO and says, this is a, and you'll first of all freak out. You're like, oh my God, it's a prosthetic. And you go, oh, it's an ankle foot orthosis. I got this. The first time you see it, you'll freak out and you'll totally forget what it is. And then gradually you go, oh, okay, I've got my sanity. I'll be okay. There's not a lot of questions you can ask about prosthetics and orthotics. There's not going to be specific questions about pin care for, well, actually, let me take that back. There's not going to be specific questions about the pins in the halo where you have to tighten them or torque them or anything like that. There may be questions about pin care. Right? This is like a bloated. Okay, I like that. And when it comes to pin care, so pin care is a wound. Right? So what should we do for the pin care? What do you think we need to do to protect the holes that the pins are in? Just like any other wound care. Keep it what? Degunk it. Keep it moist and keep it covered. That's it. Yep. That's the extent of pin care for a wound. And a lot of times the covering will take care of itself, because usually when those pins embed, the skin kind of sucks around them. So usually it's pretty covered. You may just get some pussy discharge around the actual pins you have to clean out. Yeah, it's not nasty at all, no. As long as it doesn't stink, you're usually okay. I mean, I have had some where they've gotten infected, and that's a problem. If you notice an infection in like the pin care for a halo, that's going to be something you're going to have to get taken care of right away, because think about it. It's sitting right in the skull. That infection's 3/4 of the way through the skull. It doesn't take much to go that last quarter of the way in and end up infecting the brain, and I'm getting some sort of a brain infection. But let's think about prosthetics now and gait deviations. So when we're talking about prosthetics and problems, we typically aren't going to talk about prosthetics for the arms and the shoulders. And I'll be 100% honest, the chance of you getting a prosthetic question for the upper extremity is pretty low. I've not seen one. It doesn't mean they don't happen, but I've not had a single student report back that they've seen the prosthetic question for the upper extremity. I mean, one of the either therapy ed or Score Butters Can't Witch has a question about, if you have an amputation above the elbow, this is known as a above elbow amputation. That's like the extent of the arm. The leg is definitely a key one, because it's one of the things we primarily deal with. Who would deal primarily with upper extremity prosthetics? Yeah, usually OT or hand therapy. So if you have a PT that's a hand therapist, they may deal with it too. So it's pretty rare that we get them, but lower extremity prosthetic, oh yeah. Oh yeah. So let's just put our logic caps on. So we're going to take off our, I'm clueless right now because we're talking about prosthetics. So just put logic caps on. What could cause a patient to have deviations with the prosthetic? What do you think? Okay, improperly fitted. Good. And that is a big one, right? Because improperly fitted is a huge gambit. This could be that literally the socket is not right for the patient, right? Maybe when they ordered it, they didn't fit it right, right? It could be the patient's lost weight, right? And now their leg is small. Could be, yeah, it could be that they're not wearing enough socks. They don't have the right connection. So improperly fitted is a big one. Putting it on incorrectly. Yeah. They've got the foot facing backwards, like that patient I talked about. So, I mean, that's entirely impossible. They don't have the right socks on. They decided to put just a regular sock, and I've seen it. They'll grab a regular sock out of their drawer and put the regular sock over their leg and not the prosthetic sock. Open wounds. Yeah, exactly, right? If I've got an open wound on that prosthetic, that residual limb, I'm going to be kind of gimping it a little bit, right? And what do you mean by fear of patient, Adrian? You fear of patient of wearing it? Is that what you mean? And using it? Yeah, they don't have confidence. There we go. Yeah, exactly. Right. Could be that they haven't built the confidence that that's there. Right. And you'll see that a lot. What's that? What do you think that deviation is going to look like if they don't have confidence in that prosthetic? What's going to be reduced in terms of gait? We're always going to relate this back to gait. Yeah, weight bearing on that side, right? So the stance phase, remember, because that's the way they're going to define a lot of these. They're going to be talking about going back to your favorite thing in the entire world, those wonderful gait cycles, right? And for those of you that don't remember it, that would be one thing. If I am a person right now that's going, I need to freak out and I want to study something, go back and relearn your gait cycle. So go back and review the Rancho scale and then the standard scale so that you remember what they are. Because that would be a good, if you want an assignment to start studying for the boards, there's a great assignment for it. Because most of you at this point have forgotten about all the gait cycles. You just remember maybe toe off or heel strike. And you don't remember what that even means. But yeah, weight bearing on that leg, right? If I've got a prosthetic and I put down on that leg and I quick get off of it because I don't have any confidence in it. Same idea if patient had a total knee replacement, right? It's not that much different. All right, so we've got a couple good ideas. Anything else you can think of that might cause a... So with improperly fitted, what else could be the problem with the length of the prosthetic? Could be what? Too short or too long. Yeah, right. And now the good news for that is most prosthetics have a built-in piston that the orthotist or the prosthetist can adjust it a little bit if it's too short or too long, right? But sometimes, let's think about it. We've got patients. Patients like to tinker with everything. And the patient may think, well, this just doesn't seem to work for me. And so they start messing with their prosthetic. And now that's too short because they screwed with things. And you're like, don't, why'd you do that? Right? Could muscle imbalance be a problem too? Meaning they haven't gotten used to their muscles that have been either pinned or, yeah, right? I maybe don't have confidence in my quad. I have confidence in my hamstring, but I don't have confidence in my quad right now. And so I'm going to develop a little bit of muscle imbalance. What was the major thing I said we need to avoid with prosthetics that could be a problem? The big number one thing we have to avoid. When we get an amputation, what is the number one thing? Well, infection. Okay, yeah, it's one of them. That's not the major one. What could happen to the residual limb, the leg? It could get something with the muscles. Where the muscle gets really short. Contracture, yeah, right. So think about it. Let's say I've got a below knee amputation. That's okay. That's why we're doing this. What I'm trying to get through you guys here is if you can think logically like this, you can get through the prosthetic questions pretty easily. Because when you look at them, you just go, oh, well, that makes sense, or at least does to me. That's the way and I'm hoping that I can instill a little bit of that kind of just don't think totally physical therapy here. Think a little bit common sense. And for those of you that have any sort of a like home improvement or mechanical mindset that you do stuff around the house, just think the same thing. What would happen if I was building a box or something like that? Look at the same thing with prosthetics. Yeah, I get a contracture. So now my hip flexors contract. Well, now I'm going to be like hunched over, aren't I? In order to make sure that foot touches down. So I've got a contracture. So that's going to be a gait deviation. And all of those previous gait cycle problems we talked about, right? Gluteus medius gait, gluteus maximus gait, quad gait, circumduction, right? Scissoring gait. All of those are common gait deviations. So we're going to start looking at lateral trunk bend first. So I'm going to actually maximize this window. Can everyone see the video window? Just want to make sure you can. Okay. So let's look at lateral trunk bend here real quick. Now, what I want you to mainly focus on, I know that there's a person talking on this. That's fantastic. You can listen to the person if you want. I want you to more look at the person walking with the prosthetic.
Lateral trunk bending is characterized by a significant leaning of the torso toward the prosthetic side.
All right. Oh, good. I stopped it right at the right time. Look at this kind of gait deviation. Right? Do you see how you can clearly see his pelvis is like that? Yeah, lots of bending. So again, let's take off our physical therapist assistant hat and let's put on our logic hat. Let's put on our, we're building a Lego set hat here. What could cause this? Okay, there you go. Could be too short. That's probably my number one thing I'm going to check. The prosthetic is too short. Let's check it, right? How could we check that then? What could we use? What did you learn in Therex 1 that you might be able to use for that? You had a comp on it. Okay, you could use GONI. That's not really where I'm going with it. You had a comp on it where you measured from an ASIS. Yeah, tape measure. Yeah, body measurement tape, right? Do a true leg length. Because the prosthetic is going to have a virtual malleolus. And that virtual malleolus should be about the same length as the other malleolus, right? Now, you lay them on their back and you look, and all of a sudden this leg is 3 inches up compared to the other leg. We've got a leg problem. Shoe could be too thick, right? Especially on which side specifically, Kelly? The left side, the good side, right? Yeah. Maybe he's wearing a different shoe than when they fit the prosthetic, right? Maybe now he's wearing his diabetic shoe, and before he was wearing, I don't know, Crocs, because everyone loves Crocs. Good. Justin does. Let's also think, let me erase my drawing here real quick, and I want to draw something real quick to kind of make you think something else that could be. Let's look here. What gait cycle does that look like with the triangle I drew of the pelvis? What causes a contralateral hip drop? It's a condition. Trendelenburg. There we go. Yeah, right. So could that be weakness of this glute med over here that's causing this? Yeah. Do you see what I mean? What I'm talking about, just kind of thinking through them a little bit. Don't totally freak out. Don't spaz out. There's not going to be videos on your boards, but you might get a patient that looks like this, a photo that, well, hopefully the photos will look better than this, like 2018 or 2008, there's what I can speak, video quality. But this patient will say, this patient has lateral trunk bending to the right. What could be a common prosthetic problem? And you're going down and going, oh, it could be too short, Trendelenburg gait cycle, shoes too thick, right? Could you also, and along with that Trendelenburg thing, could I have a contraction of my QL up here? Yeah. Right. So there's a couple things that could cause this. And it's not that this, and I'm probably some of you are going, Mr. McKeever, you've had years in this and you're saying it's not that difficult. But it's really not. It's not rocket science to kind of think through this. This is just basically becoming Detective Pikachu.
This deviation occurs at mid-stance and is best viewed in the coronal plane. Lateral trunk bending can occur when the prosthetic foot is excessively outset. In this case, the individual leans to place more of his body weight closer to the support point of the ischium, placing less demand on the gluteus medius in controlling the pelvis. At the same time, the compensation reduces pressure on the lateral distal femur. Insufficient length of the prosthesis may also cause the individual to lean toward the prosthetic side.
Hey, we guess that.
If the socket is abducted, often in conjunction with a residual limb which is relatively short, lateral trunk bending may occur.
Okay, so what you just said is, if the prosthetic or the limb has an abduction, either the prosthetic socket is wrong, right? So that, when he comes down, let me grab my pen again here. right? So if here's the leg and it's coming straight down, if the socket instead goes out like that, that could be a problem. Or the leg could be stuck in an abduction and he's like that. That could also be two reasons.
In this scenario, the individual attempts to avoid pressure on the lateral distal femur. A longer residual femur allows pressure to be borne over a greater surface area, which results in decreased pressure over the distal residual femur. Lateral trunk bending may also be an antalgic or pain-alleviating gait mechanism from a bone spur on the distal.
Look at that bone spur. So quick, going back to our medical imaging here, what type of medical imaging is this, do you think? If you had to guess. Yeah, it's an X-ray. Good.
Lateral femur. With this condition, significant modification to the socket may be required, surgery may be indicated, and freedom from pain may not always be possible.
Looks like he's got devil horns on the end of his
An individual with weakened
femur.
hip abductors may also display lateral trunk bending. In this condition, the individual is not initially able to control pelvic tilt in stance phase. Exercise and physical therapy may often improve the outcome.
Well, that's nice that exercise and physical therapy might improve the outcome because guess what? That's what we do. All right, so now we're going to talk about, we did that lateral trunk bend. Now we're going to talk about drop off. And this is one that I definitely can't demonstrate, so it's good they have a video about it.
Drop-off occurs in late stance as the individual is progressing from single limb support to double limb support.
Are you guys seeing that little bit of drop off when he walks?
Drop-off occurs in late stance as the individual is progressing from single limb.
Okay. So putting our Detective Pikachu hats on again. What could cause that kind of that drop? One of the things we already covered, like a tiny bend. Good, right? So maybe he's got it's a hyperflexion of the actual joint socket, right? There's a problem with the joint socket, could be where it's, or not joint socket, but the joint flexion point. There's a problem there. He's stuck in maybe a little bit of flexion. It's not extending fully. Could be. Not confident. Yep. Not very confident in his gait. Could we also go back to a Trendelenburg maybe? Yeah, and we could. What you'll find is Trendelenburg is a pretty common one for most deviations, right? So let's see what they say the problem is.
Limb support to double limb support. The weight-bearing period for the prosthetic side is prematurely and abruptly shortened, resulting in sudden knee flexion, as seen here. This deviation is often found when the keel or toe lever is too soft or too short.
So the keel or the toe lever is the thing that's going to cause the knee to actually bend, which we already covered, right? That there's a tiny bend in the knee when there shouldn't be.
Another cause of drop-off is when the shoe heel height is too high for the current prosthetic.
I think Kelly said something about shoe height before, didn't she? It's almost like she's prophetic.
Foot.
All right, so lateral whip. If any of you watch me walk, lateral whip is what I have when I walk. I don't know if any of you have ever actually watched me walk. It's kind of scary if you have, but I have lateral whip even without a prosthetic.
Whips, both medial and lateral, are typically caused by...
I do have supination, but one of the problems I have with that, because I have a short leg, the way I walk is through lateral whip with my right leg. So we're going to figure out one of the reasons why I might do lateral whip then. I might have just given you a hint.
Malrotation of the knee bolt.
So let's look back here again. Watch the leg when he's walking.
Whips, both medial and lateral, are typically caused by malrotation of the knee bolt.
Okay, so she gave us one of the things already. She said malrotation of the knee bolt, right? So that means what's happened to the foot probably? It's pointed what? Out, yeah, right? So the toe's out like this, which means he doesn't have a good toe to plant down on in, what's that called when the toe, or when you're pushing off? That's called toe off, right? So he doesn't have a good position to come down. So he whips that foot out to get it around, right? I also gave you another thing. Could be prosthetic length, right? Because I'm doing that lateral whip and almost a circumduction, but not quite there, in order to clear the foot going out and around. That's what I have on my right side when I walk. And it's funny because every time back when Dr. Ciccatelli was the kinesiology instructor, he's like, so we're going to bring Mr. McKeever in to show you absolutely all the ways not to walk. Thanks.
Careful observation of the direction of the heel at toe off can suggest the solution.
From the front of this view is the easy way to see this one.
When the heel of the prosthetic foot moves laterally in the very beginning of swing phase, the individual is said to have a lateral whip. If the knee axis of the prosthesis is in excessive internal rotation, the heel will be away from the midline of the body at toe off.
That doesn't look very comfortable, does it?
Internal rotation occurs in non-pathological gait at all major lower limb joints throughout swing phase. Between mid-stance and toe off, external rotation occurs. In the gait patterns of individuals with amputations, the internal rotation during early swing is a correction of the limb toward the line of progression as the limb is repositioned for the stance phase that will follow.
So what do you think you're going to hear in this case when they're walking? What's going to clue you in? Yeah, right? It's going to sound like a kid, right? Especially when he plants down on in this case, we got a right prosthetic, correct? So every time they kind of plant down, it's going clunk, clunk, clunk. Like, oh, I got a problem. So going back to that, what's the best way to diagnose one of these? Well, the best way to do it is exactly what we're doing here. Get out your good old iPhone or your Android for like the one or two of you that have green team, and say, is it okay if I record you for just a few moments walking? Because I want to make sure that I get what the problem is with your gait cycle. And also that way we can watch it together. Because do you think the patient knows he's doing it? Probably not. Yeah. No, they're probably just going, I'm walking normal. So leg length is probably the number one reason I see this. But again, if you have that malrotation of that socket, that can be a problem too. Other thing that could cause malrotation, maybe you have a bundle of the stock on one side. So they put the sock on, right? But instead of using, you know, a new sock, which is nice because the socks after they get washed, they kind of shrink up and get nice and fitting. Maybe they use a sock from yesterday that they already used, which is stinky and whatever. But because that's stretched out, it might roll down on the inside. Now that's going to cause that malrotation as well. So we got to look at the sock as well.
When aligning the prosthesis, the knee bolt is deliberately placed in approximately 5 degrees of external rotation so that during the anticipated internal rotation of early swing, the limb will track closer to the line of progression.
All right, so we saw a lateral whip. Guess what we're going to have now? Medial whip.
If the knee axis of the prosthesis
trying to get pause at the right spot here.
Excessive external
I almost had it.
Rotation, the heel will move closer to the midline of the body immediately following toe off, and a medial whip will be seen. A medial whip may also
you may have a little bit of medial whip.
Yep. Prosthesis is incorrectly donned in external rotation.
So stop asking me if I want to buy YouTube. I want to go back to that one real quick. Let's watch this one more time. And she said there was prosthetics, but let's just think if there's anything else we could think of that could cause
this. If the knee axis of the prosthesis is in excessive external rotation, the heel will move closer to the midline of the body immediately following toe off, and a medial whip will be seen. A medial whip may also result if the prosthesis is incorrectly donned in external rotation.
So she's talking about prosthetics, right? Could there be anything else you could think of? So she's saying the prosthetic is either externally rotated too much or it's just not donned correctly. Could swelling cause this? Swelling could actually cause either medial or lateral whip, but yeah. right? So that means we got to take a look at that residual limb. Like I think Kelly said earlier, a wound, or whoever said earlier, right? Oh, we might get a wound there, so let's go take a look at it. The other thing I've seen sometimes with this medial whip is, for whatever reason, sometimes this knee socket gets loose and it's not as stable as it is. For whatever reason, when I've seen it in the field, it usually ends up in a medial whip situation. And I'll be like chasing down every single thing in the world until I get to, oh, well, the knee socket's too loose. Pelvic elevation.
Pelvic elevation, or hip hiking, occurs between initial swing and mid-swing. A slight elevation may be seen at the hip on the prosthetic side as the patient begins swing phase.
Okay, so before she talks about this one, what could cause me to elevate that pelvis? No knee flexion. Good. Yep. Right. Exactly. We had that with regular gait. So the knee's not flexing right. What else? Could shoe height be again? Yeah, too long or shoe height. Yep. So that could be a problem. Yeah, it could have hip flexor muscle weakness specifically on that other side, but also could have tightness up here and what? Yeah, QL. Yeah, so there's a couple different reasons here. So let's see what she says. See how smart we are.
Although it is a moderate deviation, it is accompanied by a significant penalty in energy efficiency. It is commonly caused by a prosthesis that is too long or...
Woohoo! Claps for everybody. Where is it? Here we go. There we go. Claps for everybody.
Prosthetic knee with insufficient friction. A rare cause of this deviation is an excessively strong extension assist in the prosthetic knee.
All right, so now we got pistoning. So when you think pistoning, think of your inside your car engine, right? The piston that's driving up and down.
Pistoning occurs when the femur moves vertically during alternate weight-bearing and non-weight-bearing periods during gait. This deviation is being demonstrated in a non...
Okay, so there's what pistoning looks like in the socket. That can also occur down at the below knee amputation as well. Why do you think the socket would be bouncing up and down like that? Not fitted correctly. Good. There's one. Sure. Right? The prosthetist, or maybe the patient lost weight, right? What else? What could they not have enough of on? It does look painful, right? Yeah, enough socks, right? They're, for whatever reason, their leg's not as swollen as it normally is, so they don't put enough socks on it. So now that piston or that socket doesn't have a good grip. It could also be if they have one of those prosthetics that when their residual limb comes down, that they have that little pin down here. That pin may not be all the way down into lock, right? Because that socket's going to come down here, and then you're going to have this little hole here that the pin goes in. The pin's going to go down in here and lock in place. They may not have the leg fully down into the socket as well.
Ambulatory mode. Pistoning is often seen in conjunction with vaulting, a compensation used by the individual to clear the prosthetic limb in swing phase. Inadequate fit or suspension may cause pistoning of the prosthesis. The deviation may often be corrected by auxiliary suspension. In some cases, the socket may require modification or refit.
So let's say we see that in a socket. What else are we going to want to check? Not just of the prosthetic, but what area? What are we going to want to look at? Take the prosthetic off and look at the what? Yeah, the residual limb, right? Look for any kind of wounds. Because that thing's been pistoning the whole time they're coming into therapy. They're going to have probably a start of a pressure injury. So we got to check it out, right? And what she said about using this strapping, sometimes this is the cheap way if we can't afford to, maybe the patient can't afford to get the socket refit, they'll put some strapping on to kind of pull that prosthetic back up and hold it in place. It's definitely the cheaper way to go rather than just getting it reset. All right, vaulting.
Vaulting is the pronounced plantar flexion of the sound ankle, which elevates the center of mass to assist in clearance of the prosthetic limb during swing phase. A prosthesis which is too long will cause the individual to vault over the limb.
Guess she already gave us one of them. So she said the one problem is the prosthetic's too long, right? Because they're going to up and really up into, what's that gait called when they walk on their tippy toes? What type of a gait? Nay. The horsey gait. Yeah, the horse gait. Good. Equine gait, right? Where they have that kind of, and when I see this, I normally think of kids, right? The kids that walk on their toes. So she already said the piston, or that piston, the socket's too long. Could it also be as a contracture of his calf? On this good side. Yeah, right? And we'll see that when he sits down or when he lays down and you look down at his foot and his toes are kind of constantly plantar flexed. And you go to move those toes, you're like, ooh, boy, feel that calf and how tight it is. And we all have a little bit of tight calves. I pretty much can guarantee if we go around the whole classroom, most of us have pretty tight calves. It's just one of those things that we get, it just happens, right? So stretching the calves feels really good for this one. So we may have to stretch your calves out a little bit. He may develop a contracture of the calves because he's doing this.
During swing phase. The presence of excessive knee friction will cause this same deviation as the individual attempts to clear the forefoot of the prosthesis. The individual can easily develop vaulting as an inappropriate gait habit, however subtle.
That last guy just looked like he was having fun. He looked like he was skipping down the road.
Excessive heel compression markedly lowers the center of gravity and delays rollover. It can be observed best in the sagittal plane in early stance. The intact limb uses a modest knee flexion arc of 15 to 20 degrees to absorb the shock of floor contact and to smoothen the pathway of the center of mass. Some prosthetic feet rely on a compressible heel to do this. The time needed for adequate compression delays the drop of the forefoot to the floor. This perpetuates an unsteady, heel-only source of support that requires increased active muscular control of the knee and hip to ensure weight-bearing stability.
Okay, so what she's talking about here is that there's that extra compression on the back side of that heel when they're walking, right? The number one reason I've seen this in the field when I was working with these patients is poor fitting shoe. Now there are problems that could be with the prosthetic for sure, right? But you know, again, let's use Occam's razor, right? If we're in the field and we hear hoofbeats, we should think horses. First thing we should check is check that shoe, right? It just may be that it's not tight enough, right? And so that shoe is constantly kind of picking up and closing down, and that's affecting the compression of that heel source. And we just solved it without having to call the prosthetist. Now, if we check pretty much all that, we check the shoe, we make sure the socket's on, you know, we're going to do the same troubleshooting steps no matter what the gait deviation is, right? We're going to check the residual limb. We're going to check to make sure they have the appropriate socks on. We're going to check the actual socket itself to make sure there's no problems there. We're going to look for any pressure injuries. We're going to look at the shoes. Are the shoes different than normal? Are they tied properly? And once we get through kind of all that, and we've ruled out all of the stuff we can fix, then we call the prosthetist and say, hey, bud, I think he's got a problem. And most of the prosthetists in town, for the most part, will get the patient in pretty quick. Because think about it, if this is just a minor adjustment on this heel, how long is it going to take them? Maybe 5 minutes? Got maybe 10 minutes to watch and make sure it fixes. It's not that big of a deal. And, you know, their money's right in this. They paid a lot of money for this prosthetic.
The illustration shows increased muscular activity of the lower gluteus maximus in terms of both timing and intensity for a typical transtibial amputee compared to non-amputee activity. This is true of all prosthetic feet, whether dynamic response or the relatively inert Satch foot. A similar result is seen in quadriceps activity. Heel cushion compression delays the rate of initial tibial advancement, resulting in reduced knee flexion during the weight acceptance period. Excessive heel compression can be addressed by stiffening the heel cushion.
All right, we got excessive toe out.
Excessive toe out can best be viewed from the frontal plane. This deviation occurs when
Hey, he looks like Mr. McKeever.
there is too much external rotation of the prosthetic foot relative to the line of progression. The appropriate amount of toe out depends upon the individual. This deviation may also occur if the individual wearing the prosthesis maintains external rotation at the hip. In either case, the toe lever of the foot is effectively shortened and the individual passes over the forefoot section too quickly.
Okay, so like you said, between this one and lateral whip, is that what you're asking? So with this one, if you did, so let me go back real quick. There's not a hard whip with it. This is just the toe is turned outwards and they're trying to compensate by walking kind of normally. With lateral whip, there's going to be a kick out of the foot. And now the one lady did have kick out, so she actually has lateral whip too.
Excessive toe out can best be
But if you
viewed
look, there's
from the
not a
frontal
lot
plane.
of the leg is not moving out like this. But both of them can be the same problem. Both of them can be that the foot is externally rotated too much. Usually what I see is with lateral whip, that is way externally rotated, whereas here it's just a little bit. And you may the patient may say, you know, it's really uncomfortable when I'm planning down. It doesn't feel right. And then we look and like, oh yeah, the toe's just out just that little bit, right? The main thing I've seen here with these types of patients, and she mentioned it briefly, is their external rotators are tight. So not necessarily with the prosthetic even. It's whatever reason, right? Maybe they slept for a couple of nights or they've been laying down watching TV for too long and they laid with their legs kind of rotated outward. And because of that, they got a tight external rotator, which means we're going to do what? Stretch them. Yeah. Shove them in the stretcher. No, stretch them. All right. Before we get any further here, we're going to have valgus and varus. Right? We're going to put a 1 over here. I'm going to put 2 over here. Which of these represents valgus? 1 or 2? Yay, round of applause, right? Valgus, the legs make an inside L. Whereas varus, the knees are very wide. So we remembered that from Kines. I'm happy. That makes me feel good. At least you learned something from me.
A valgus moment occurs when a slight medial shift of the knee can be seen as the...
Now, real quick, I'm also seeing a little bit of lateral whip here. So this is one where we're going to have to find the chicken or the egg. Is the valgus causing the problem or is the lateral whip causing the problem?
Individual with an amputation nears mid-stance. It is very undesirable as it places undue pressure on the bony areas around the head of the fibula and the transected end of the tibia. It is generally caused by insufficient medial displacement of the foot relative to the socket. Inversion of the foot can also be a source of this deviation, as well as poor integrity of the medial collateral ligaments.
So again, when we have the valgus of the leg, it's going to be pretty easy to see because even in stance phase, you're going to see this. And so she said that a lot of the problem there is going to be here, or the placement of the foot when they're walking is going to cause it. And there's placement of the foot could be tightness. It could be, any number of reasons why they're doing it up here in the leg. Could it be a little bit of internal rotation? Maybe. Could it be a little bit of adduction contraction? Sure. The first place I'm looking is at this knee socket and seeing, okay, do they have the socket in properly, first of all? And then also, is something going on where maybe this side out here is built up versus this side, so it's pushing it in. That's a varus. Well, that must be the opposite, Mr. McKeever.
In optimizing the alignment in the coronal plane, the prosthetist seeks to mimic the slight varus moment seen at the knee during mid-stance in normal human locomotion. This moment results in a lateral shift of the knee, about 12 millimeters or 1/2 inch, and is usually achieved by a modest medial inset of the prosthetic foot relative to the socket, somewhat similar to the alignment of the foot-knee complex of most non-amputees. A slight varus moment is created with a consequential lateral shift at the knee and increased pressure on the proximal medial and distal lateral regions of the residual limb. Pressure in these areas is usually well tolerated.
So she just said pressure in those areas is usually well tolerated. That means those areas are pressure tolerant areas. And again, whether it's pressure tolerant or pressure sensitive, how long until that redness should go away? 20 to 30 minutes, right? Yep, exactly. 15 to 20 minutes would be ideal. But definitely by 20 minutes, I want it to be going away.
An excessive varus moment can result from too much inset of the prosthetic foot.
Now looking at that, the foot's way further in than the other feet were. It can also be caused
if the medial lateral dimension of the socket is excessive. In addition, when the prosthetist attempts to...
Does this patient also have toe out? Yeah, right? So again, this is where we go back to that chicken and the egg. Right, we got to go, okay, is the toe out being caused by excessive varus, or is the varus being caused by excessive toe out?
Match the toe out of a person with extreme external rotation. The resultant placement of the heel is more medial during the loading response period and can create an early excessive varus moment. Occasionally, this deviation is seen in an amputee with hypermobile lateral collateral ligaments. The varus valgus collateral ligament stress test should be applied to any person demonstrating excessive coronal plane motion at the knee. External rotation of the foot at heel contact is best viewed in the coronal.
All right, so now, I know that somebody's going to say, isn't this toe out? Do you see the little bit of a difference between when it was toe out and there was no movement at that foot socket? Let's walk back here real quick. And now watch the movement at the foot socket.
External rotation of the foot at heel contact is best viewed in the coronal plane as the individual approaches. It is characterized by a lateral movement of the forefoot at the beginning of stance phase. This deviation may result when the heel durometer of the prosthetic foot is too firm.
Heel durometer. Yeah, he pivots at heel strike. Exactly. Heel durometer is a fancy way of saying gizmo in the heel. Are we going to fix that? Nope. That's going to be a prosthetist call. Honestly, if you see this, when you see movement of the prosthetic that's not caused by socks, because socks we can fix. We can put more socks on, take more socks off. But if you see an abnormal movement, maybe you see the knee socket kind of shifting back and forth. You see the heel socket shifting back and forth. At that point, it's just call the prosthetist. Hey, Bob's got a problem with his prosthetic again. He was playing kickball and busted it.
The prosthesis may externally rotate around the residual limb if appropriate socket shape has not been provided, particularly in the popliteal region.
I see that common deviation when I'm in the hospital and they give them the temporary prosthetic. Because that temporary prosthetic is usually pretty beat up. And they're just using it so the patient can stand up to go pee or something like that. And it's just an older prosthetic and it's pretty beat up. And so oftentimes that heel socket just gets worn out. At that point, I'm not too worried about it with the temporary prosthetic. I'd be more concerned if it was the permanent one. Foot slap. Oh, we almost talked about this before. Wait, is this going to be a problem with their tibialis anterior, do you think? That was a trick question. Why is it not going to be? Why is it going to be no? They don't have a tibialis anterior.
Foot slap is characterized by an obvious rapid and uncosmetic plantar flexion movement immediately after heel contact. It is most commonly the result of insufficient plantar flexion resistance in the prosthetic foot.
Okay, so I didn't realize she was going to answer it that quickly. Boom.
An excessively soft plantar flexion bumper in a foot with an articulated ankle may produce this deviation.
So again, foot slap, the major problem is the ankle. Now, in a normal, healthy person, yes, foot slap would be tibialis anterior weakness, right? But if you get an amputation, you know, that's not going to be the problem, right? Just like, you know, they're not typically going to have toes to scratch. I'm just saying. All that's kind of common when you have an amputation. So hyperextension of the knee. Oh, we've talked about this before. What's that gait called again? Janu Recurvatum. Good. Yeah. I think this is the one that kind of makes me sore watching it.
Historically, hyperextension of the knee was a deviation more commonly seen when large numbers of amputees were being converted from a joint and lacer design to a patella tendon bearing design. The joint and lacer design is effective in transferring weight bearing above the knee, as well as providing increased medial lateral stability. When the purpose for the joint and lacer is to displace weight bearing to the thigh, it is desirable that the knee remain in extension throughout stance phase in order to shift weight bearing proximally. An articulated ankle will encourage knee extension and thus facilitate this transfer of weight to the thigh. An articulated ankle improves weight acceptance and stability by providing a relatively unopposed plantar flexion motion, allowing an early foot flat posture. While an extended knee during stance phase may be desirable for an individual wearing a joint and lacer design, hyperextension is never desirable.
Never.
Hyperextension, though relatively uncommon, is particularly undesirable in the patella tendon bearing or total surface bearing designs. When hyperextension is present, it can best be observed just prior to heel off in the sagittal plane. The prosthetic causes of hyperextension include a heel cushion which is too soft, or a heel or toe lever arm that is too long or too firm, considering the weight and activity level of the individual.
I don't know why that gets me.
Anatomically, hyperextension can be caused by laxity of the posterior capsule of the knee or hamstrings tendons. Persistent hyperextension may require the application of a supracondylar, suprapatellar PTB style socket. Using the suprapatellar design, careful attention to the anterior proximal trim line and contours can limit hyperextension.
All right, so one of the things I want to talk about, so I want to go back to find her where she's in a hyperextension here real quick. Of course, I can't get it. There we go. A little bit. So when she's in this hyperextension, right? Boom, boom, that knee's kind of bent backwards. Where is a ton of pressure going to be applied? So if I've got my leg and it kind of, there's that and that anterior socket. Yeah. So this is, so if you think the patient has, you're like, oh man, because it is uncommon. I'm not going to get, I don't think I've seen a hyperextension of a prosthetic patient. Normal patients, sure. I've seen plenty of normal patients with hyperextension of the knees. But prosthetics, I don't think I have. Talked about it in school, but I don't think I've ever seen it. So one of the things, one of the things that our P&O teacher taught us when I was in school was, if you think that the patient has hyperextension of the knee, the first thing to do is take the socket off and look at the anterior capsule of the knee. Because if they're having hyperextension, that's going to be really red, because that is a pressure sensitive area, right? It's not used to, you're not supposed to be weight bearing on that front portion of it. It's supposed to be on the main portion of the bone. So she said a lot of the problem's probably going to be in the socket here or in the heel itself of the shoe. Both those problems, not much we can do about it. You could also theoretically have it if you have a buildup of sock back here, but that would be, I mean, that'd be a pretty rare case. So, you know, stuff like that. Again, hyperextension, not as common as the other stuff.
Ensuring appropriate knee flexion in a transtibial amputee is one of the most challenging aspects of the dynamic alignment process. Static alignment often makes use of the subcutaneous crest of the tibia, or tibial blade, to establish alignment of the residual limb within the prosthesis. The socket is set so that the tibia is tilted slightly forward to avoid a backward thrust during stance.
And look at those body mechanics.
This angular posture of the prosthetic socket, in conjunction with a deliberate anterior translation of the socket relative to the foot, generally succeeds in encouraging tibial progression. It does not, however, result in normal knee flexion during stance, which is invariably significantly less on the amputated side than on the sound limb. The graph shows typical reduced knee flexion on the affected side, illustrated by the purple line, contrasted with near normal sound limb knee flexion, illustrated by the green line. This reduced knee flexion is seen in nearly all persons with a transtibial amputation.
So what she's literally saying here, because she used a lot of big fancy words, what she's saying is a little bit of inadequate knee flexion is completely what? Completely normal. Yeah. Right? Because it's not the patient's normal knee. That makes sense. It's not a normal leg. It's not their normal limb. Yeah, so they're not going to necessarily have fully normal knee flexion on that affected side. And a lot of patients may say it just feels off. And what you tell them is, I understand it does, and what's because you have a limb replacement. It's going to feel a little off until that becomes your new normal.
Reduced knee flexion is even greater in the individuals with general muscle weakness, often a characteristic of dysvascular amputees. In observational analysis, the degree of knee flexion can best be observed by noting heel rise in the sagittal plane during late stance. Pistoning occurs when the tibia moves vertically during alternate weight-bearing and non-weight-bearing
So it's the same thing as the other one.
Periods during gait. It is best seen by viewing the popliteal region as the individual walks directly away from the observer. Pistoning is most commonly seen when the socket is too large or the suspension is inadequate. The deviation may be corrected by modifications to the socket or to the suspension mechanism and by adjusting sock fit. On occasion, the socket may require refabrication.
Excessive heel rise is best viewed in the coronal plane as the individual walks away from the observer. However, it can also be seen in the sagittal plane. It is characterized by a heel that moves abnormally high during initial swing. Excessive heel rise usually results from inadequate resistance to knee flexion. This deviation.
So what she just said is it's inadequate reaction to knee flexion. So what they're literally trying to do is kick that foot out in order to get it to extend. That was pretty, I mean, it looks like they're doing a front snap kick there while they're walking, right? It's a complete kind of kick out in order to get that knee to go locked. Didn't we have an abnormal gait for that? You know, it's something that has to do with stepping. Karate gait. Yeah, right? That kick out gait. That's kind of what we're looking at here. It's the same idea with the knee or without the knee. It's just that the knee's not properly working.
Deviation is problematic as it delays swing phase
kick.
And thus reduces walking velocity.
And, you know, all of this, one of the things you can notice about all of these gait deviations is what's it going to do to the patient's energy reserves? All of these gait deviations. It's going to wipe them out. Yeah. Right. So the sooner we can get it fixed and get them out of a bad habit, the better.
Knee instability is an unacceptable gait deviation which can render an otherwise excellent prosthesis unsafe and unusable. In this condition, the knee flexes uncontrollably at loading response. A visual reference line has been traditionally used to place the socket, knee, and ankle in an appropriate spatial relationship as viewed in the sagittal plane. This is referred to as the TKA, or trochanter knee-ankle line, and can be seen here projected upon the lateral surface of the limb. Knee instability can occur when the socket is too far.
Yeah, so Erica's like, did he fake that? I'm hoping that he was doing it for demonstration purposes. It could have also been, and you know, sometimes, you know, we'll see it in PT, and this will be one where we want to take a recording of it because this is such a kind of odd deviation. I mean, yeah, I'll agree with you there. Okay.
Line. Due to the inherent mechanical stability provided in contemporary knee designs, historical concepts about the TKA line may not always apply. Specifically, the knee may in some cases be placed anterior to the TKA line and still allow for a stable knee posture throughout stance phase. For example, microprocessor knees typically have a stance phase stability mode which is stable regardless of alignment. Knee instability can also occur in early stance phase when excessive resistance to plantar flexion is caused by a heel durometer or plantar flexion bumper that is too firm. If an articulated prosthetic foot has no resistance to dorsiflexion or is aligned in excessive dorsiflexion, the prosthetic tibia may continue to advance over the foot without restraint, even to the point of knee collapse.
Okay, I'm going to say this right off the bat. If you see that, your call needs to go right to the prosthesis, right? Because that's something screwed up in that knee socket. I'm just saying, right? Can you imagine your patient walking in and he's walking in like that and you're like, hey, Bob, hold on. This will make a great YouTube video. Go walk over there by the parallel bars and fall. I hope that wasn't what this is. I hope that this guy maybe had that problem and they asked him, maybe he got a new prosthetic and like, if this is the damaged one, can you just show us what it looks like? I don't know. But for me, I'm just watching this going, man, and you're right. Because it said, don't put on Erica. When I saw him first coming down the stairs in this video, I'm like, no. Don't talk to me about a failing knee prosthetic and going down the stairs.
A short lever arm of the residual limb may also contribute to knee instability. Weakness of the hip extensors will present knee control problems that may need to be addressed through a physical therapy regimen. The gluteus maximus, a primary hip extensor, effectively prepositions the knee for appropriate stability.
So real quick, just thinking about this. So why might the gluteus maximus be weak? It might be the same reason why iliopsoas is weak. What do we tend to compensate for hip extension? Which muscles? What other muscle does hip extension? A big set of them. The hamstrings, right? Yeah. So now you think about it. I've come down here, boom, and I've cut off part of the leg. That means I've had my hamstrings partially resected too, right? I had to because the hamstrings go down and attach below the knee. So now I've changed the pull of the hamstrings a little bit, even though it's only a small amount for hip extension. But now this pull's different back here. So now I've got to rely on my glute max. But the problem is I ignored my glute max for so long, it's kind of weak. Right? So this is a common problem you'll see in patients that have total knee amputations, total knee replacements, is that they've become dominant on this rectus femoris for hip extension, right? Or hip flexion. And their iliopsoas is weak. So then they get the surgery down here and they messed up the knee. Now they can't flex the hip because their iliopsoas is so weak. So one of the things we're going to have to do is repeatedly, okay, let's do leg extension, do leg extension, do leg extension, and start working those glutes. Right? We want to get that buns of steel workout out. A little bit of beach body, right?
Flexion of the socket places the gluteus maximus on slight stretch, improving its function as a hip extensor and secondarily as a prosthetic knee extensor. This occurs just prior to loading response in order to maintain stability in early stance phase.
We already looked at foot slap, didn't we?
Foot slap is characterized by a rapid and uncosmetic plantar flexion movement at heel contact.
Yeah, we already looked at that one. I don't know why that one's back there. This is, I think, the last one here. Oh, it's circumduction yet, and then I can take a break.
Unequal step length is typically associated with excessive lumbar lordosis. It is seen when the sound side...
Okay, real quick. She just said that excessive, right, is caused by lumbar lordosis. What causes lumbar lordosis to increase again? What happens at the pelvis? Anterior tilt. Good. Right? So this is one, if we see this is an easy fix, isn't it? If this pelvis is the problem, we just go back to our low back protocols and start working those posterior pelvic tilts, baby, right? All right, let's get the motion in those hips going, right? Get the rocking and rolling.
Step length is visibly shorter than the prosthetic step length. This inequality is not merely a cosmetic consideration. Excessive lumbar lordosis has been linked to back pain, a common complaint among persons with transfemoral amputations. Since the individual is usually required to draw on any available lumbar lordosis to increase the sound side step length, flexing the socket 5 degrees assists the individual in increasing that step length.
Walk around with your shirt up over your
Therefore,
chest.
socket flexion is generally recommended for all prostheses. The presence of a flexion contracture at the hip requires even greater socket flexion to be placed in the prosthesis. If an individual with an amputation is provided with a prosthesis aligned with insufficient socket flexion, they will have difficulty achieving a normal step length. The individual spends less time on the prosthesis, further contributing to a shortened step length on the sound side. In some cases, this deviation is not correctable, even with gait training and physical therapy.
All right, last one, circumduction.
Circumduction is characterized by a wide arc made by the prosthetic limb, which...
Okay, we're gonna put our hats on for this one before she tells us what's wrong. Circumduction, even if we don't have a prosthetic, what can be some problems? What could cause me to swing that leg all the way out? Knee flexion, right? I have problems with knee flexion. Good. Yep. What else? Could I be trying to clear my toes? So I have excessive what at the foot? Yeah, excessive foot drop. Good, right? Excessive plantar flexion. What else can we add to the prosthetic, do you think, that might be the problem? The prosthetic is too what? Too long. Yeah, good. So we've covered most of it. Let's see how close we were here. See how many points we earned.
It occurs in the transverse plane and is best viewed in the coronal plane. If the knee flexion resistance is extreme, or another limitation of flexion exists, the individual must circumduct the prosthesis
and that guy's got whip
to provide
as well.
Forefoot clearance and swing phase.
I think he's just demonstrating it all.
Thus, careful adjustment of the flexion resistance of the knee is necessary to avoid this deviation. An individual may also circumduct as an antalgic gait mechanism when the medial brim of the socket impinges the tissues during swing phase. An improper brim radius or an excessively high medial brim may cause this deviation. Circumduction may occur when the prosthesis has been excessively lengthened.
Hey!
When this occurs, an examination of components and socket fit will determine if an incorrect length is causing the individual to circumduct. This deviation may also be caused by an extension assist that is too strong.
All right.
Can this beanie
protect us from foraging? No. Stupid YouTube ads. All right, so that was a lot of videos, right? But could you see how easy it is to get some form of a deviation with a prosthetic? I mean, it's pretty easy. What's going to be our main goal if we see a deviation, other than fixing it, stopping them from developing a what? A bad habit. Yeah. Right? It's easy to fix it really early on, but later on it gets more and more difficult to fix it, right? You've got somebody who's wearing a prosthetic for 20 years, getting them to fix a deviation is going to be pretty hard. So there's a lot of stuff. We're gonna go ahead and take a break because it's been a little bit here, and then we'll come back and we'll talk about home health and some other stuff. So I'm gonna pause recording here. All right, so resuming recording. When it comes to prosthetics or orthotics, are there any questions you have about prosthetics or orthotics? Is there anything that you're wondering about P's and O's or pros and O's? Is there anything that you've seen that you didn't understand before when you were out in the clinic? Does it overall make sense though? Like if it doesn't make dollars, it doesn't make sense. Get it? So when you get those, that's a good question. Again, not going to see too often, but it's a really good question. What does an upper extremity look like when it's not fit properly? Well, let's think about a couple of things with the upper extremity. Most of the times that I've seen upper extremity prosthetics has been one of two types. Either we've got an electronic control upper extremity, which are really super expensive, or a solid fit upper extremity, meaning there's no flexion in the elbow or something like that, or it's a fixed flexion in the elbow. So if it's not fit properly, well, what's going to happen is the patient's going to have problems doing stuff, specifically if it's one of those dynamic ones that has the electronic controls. When they're reaching for stuff, it's going to be wobbly. It's not going to have a good stability. A lot of the same kind of ideas. It may piston, like we saw in that other one. But the most common thing I see with upper extremities when I've seen patients with the upper extremity prosthetics is it just doesn't hold on. They end up with it, it's just kind of slips off, or you can see that it's not fully clicked on. As far as most of the upper, so what I've seen primarily for upper extremities, when I've seen patients with any prosthetics, it's been primarily hands. You know, so they've got, you know, a lot of them have that claw hand type idea. I don't know if you guys have seen that one, the one that kind of looks like the Captain Hook gripper type claw, because those are fairly inexpensive. And again, the major problem is actually just, I texted a hand therapist while we were on break and I said, what can I tell them about upper extremity prosthetics? And her response to me was, tell them to check the skin. Skin checks constantly, all day, every day. That's what our comment was, is it's most of the times with the upper extremity prosthetics, because they're so specialized, they're going to be fit perfectly. But the problem is in those pressure sensitive and pressure tolerant areas of the upper extremity that they end up with pressure injuries, pressure sores, breakdown, maceration. And I've also seen with patients with upper extremities, they don't tolerate a wear schedule as much. Meaning, you know, they can't immediately just go to wearing the prosthetic. They really have to kind of break it in, being, you know, a couple days here, a couple days there. The upper extremities are a super, super specialized field because of the things we do with our upper extremities, right? Legs, we just have to kind of walk. I mean, I know it sounds kind of basic, but it is. We just have to walk. The upper extremities, we do so much with our hands and our wrists and our elbows. A lot of those are really, really kind of difficult. And it's, again, I've barely seen, I can honestly probably tell you in like 2 hands how many upper extremity prosthetics I've had. And most of them have been prosthetics that it's nothing to do with what I'm treating. They just actually have a prosthetic. I'm seeing them for something else, like a low back pain or something. But with poor fitting, obviously it's not going to fit right. It's not going to slide on. You're going to have pistoning, all the similar stuff. You just don't have those gait deviations. And again, pressure sensitive, pressure tolerant areas breakdown is the major thing for them. And because, again, those are so specialized, especially if they've got any, you know, a lot of them have sensors inside of them that they can, you know, if they contract certain muscles, will cause the hands to do stuff. You really have to be trained on exactly what those prosthetics do in order to even remotely understand them. It's a lot like a sip and puff wheelchair. You know, not everyone is going to be trained on how to teach a patient how to use a sip and puff wheelchair because they're all a little bit different. So you really have to get specialized training on those specific prosthetics in order to understand them. If it's just a basic block hand to replace a hand, yeah, sure. And I had a couple of patients. I had one patient I remember very, this was like way back in the very beginning of my career. He thought it was hilarious that, you know, I introduced myself. I went to the hospital. He was in there for a total knee replacement. And he's like, "Aren't you going to shake my hand?" I'm like, "No, I really don't shake hands because I don't want contamination." He goes, "Well, in my area, if you don't shake hands, you ain't friends." I said, "Okay." So I reached out and I shook his hand and he disconnected the prosthetic while we're shaking it. And I ended up with his prosthetic in my hand. And he's like, "Oh my God, what did you do?" Thanks, dude. That was funny. That was real funny. Actually, now that I thought about it, it'd be totally something I would do. Like I could completely see myself by an amputation doing that to a therapist just to really freak them out. The hand ones are really interesting. There's I think I have to look. I think I've got a video of one of the new like super specialized hands that literally has fingers now that they can do individual finger movements, which is just wild. Those mechanical hands are just getting cooler and cooler to me. There's some now that they're looking at, you know, we're almost to the point of, what was the movie with STEM? I'm trying to think what that was called. The spinal implant, Upgrade. That's what it was. If you ever want a movie that's really gory, watch that. That was pretty brutal. But we're getting to the point almost where we might be able to do spinal implants to control those prosthetics. where, you know, it's going to replace the hand entirely and you won't even know that it's not a real hand, which would be really cool. Anything else? That's the best I can answer that one. Yeah, no problem. Anything about, not prosthetics, but anything about orthotics that you have questions on? Orthotics are pretty self-explanatory. You just got to play with them. And we've got a bunch back at campus that we'll play with on our lab days, just so you can kind of get used to it. The main one, again, that you guys will be worried about for most of, I mean, honestly, most of the stuff you'll deal with is the knee immobilizer. We use a lot of knee immobilizers for patients that have weak knees. So figuring out how to put those on and off is an important thing. And I will highly recommend while we're back on campus, that's one of the things you try out. All right, so I have a lecture on environmental assessment that I will post. I am not going to read through that whole lecture. It's only I think it's like 30 slides, but we've covered environmental assessment before. Environmental assessment is looking at going through a patient's house and making sure they're safe. We have covered that ad nauseum. I don't want to read through that. It will put you guys to sleep. You'll be bored and you'll be mad. So what I would rather do right now is kind of open the floor up for home health questions. So this is the point where most students, because almost every student wants to get into home health. Why do you almost every student want to get into home health? Money, yeah. The money is the real reason. The guapa, yeah, right? No, wait, guapa is handsome, right? Yeah, that's what I said. Guap is money. Okay. Oh, what? But yeah, so home health. Let me tell you a little bit about my experience with home health, and then we'll open it to maybe questions for you guys. So I couldn't do home health in Pennsylvania until we had a full year. Now that is changing. I can't guarantee when it's changing because I can't get the board to answer me, but that is changing. It will be that you'll be able to do home health right off the bat. I would highly not recommend that because it took me a little bit getting into home health to get kind of a rhythm down. So how does home health work usually? Well, you're very rarely are you going to be working for one agency. It's pretty rare as a PTA that you'll work for one agency. If you are, it's fantastic. That's great. You're usually full-time with that agency and you're expected to carry a specific caseload. But that's pretty rare. Usually you're on it's not even quite per diem status. You're just on a piecemeal status, meaning you take some of these patients, take some of these patients, take some of these patients. So when you go to a home health agency, usually you're going to go to apply and you have to go find ATE in the back. ATE will get you signed up with the home health agency. No laughs? No? Okay, I got something. Almost all the home health agencies in town are Filipino owned. I'm just gonna tell you, they really are. Almost all of them. I think there's like one or two that isn't. And usually what happens is when you go to apply there, the front desk will be like, they'll go, hey, go back, talk to ATE in the back. And she'll get you set up. And you go back to the back room, you're like, I have to talk to ATE, and 5 older ladies will turn at you and go, yes. That's been my experience in home health. But yeah, make sure you, exactly. Yeah, there's always food at the home health agencies too, always. So you're going to sign up with the home health agency. Usually most home health agencies, the first thing they're going to say is, where do you want to work at? And then you're going to go, well, Las Vegas. And they're going to go, oh, no, summer child. That's not what I mean. What they're going to say is, what zip codes do you want to work in? And this is where you kind of have to start learning your zip codes in Las Vegas and go, well, I'm okay with 8111 or 89119, 89120, 89121, whatever you want in the general area. And, or you can be like me and say, don't care. Usually, if you're the person that says don't care, you're going to get more patients. There's a downside to that. And the downside is that means you're also going to get those areas you may not want to go to. So I'll talk about that in a little bit. But once you kind of get signed up with the home health agency, there are 2 different ways it goes from there. The way I've typically had it is that I take whatever patients they send me. So the main office calls me and says, what it really was is we had this application that said, I've got a new patient, 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 I've got a new patient. I have to call that patient and schedule out the appointments with them. So I'll call, and this is, again, you have to do this. You're gonna have to do this on your own. It's pretty rare lately that home health agencies do your own appointments. Some of them do. And usually I find that if home health agencies in charge of my appointments are screwed up, so I would rather be in charge of them. So this means you also have to be a little bit of a telemarketer, right? So you have to call the patient, and usually with most patients, they'll dodge your first call because they think you are a telemarketer. You're like, hi, this is, Mr. McKeever from the home health agency. I need to schedule you to see some appointments with you. Can you give me a call back? I'm going to highly recommend that at that point, if you're going to do long-term home health, you have 2 phone numbers. Because I don't want to give my home health patients my phone number. I want to be able not to take home health calls. And if I have my home phone number, they'll call me at all times. So what I have set up for me is I have my personal number, and then I also have a Google Voice. If you have a Gmail account, you can get a Google Voice account, and it'll give you a virtual number. And that can ring to your phone. It can send you text messages, all of that, just like a normal cell phone number. And that's what I use. So I give my patient, and the other reason is my home phone number is a 717 area code, which is back in Pennsylvania. And so you see a 717 area code on your phone, you're like, Pennsylvania? I don't know anyone in Pennsylvania. So I needed to get a 702 number. Some of the other people just get burner phones. They'll get a cheap line from Cricket, or Mint Mobile is the big one that most PTAs and PTs are doing now. They go and get the cheapest Android phone from Mint Mobile because it's like $15 a month or something like that. And that's what they use for home health. The advantage to having a separate phone is when you don't want to take calls, guess what you can do to that phone? Turn it off. Right? Maybe you don't want them calling you after 8 o'clock at night. The other thing they'll ask you when it comes to that time is, when do you want to see patients? Because some patients will request specific times. I'm one of the people that will see them outside of normal business hours. So I'll tell them, I don't care when the patient needs to be seen. If they need to be seen at 1 o'clock in the morning, go see them at 1 o'clock in the morning. For a while, I had this Marine down in Lake Las Vegas who wanted his PT at 0400 every day. And no other PT or PTA would do it. I'm like, sure thing. 0400, I'll be down there. And I went down and I saw him. And what's funny is and he never refused his appointment. He was always ready. And then I got him into affiliated physical therapy outpatient, and everything was golden. I'm usually up then anyway, so why not? Right? So whatever they want to see. I don't mind seeing patients at 9 o'clock at night. Here, you'll find one thing about Mr. McKeever is I'm all about that. What did you call it? The guap. Also in Las Vegas, you have this unique period that you may see patients in either Boulder City or worse, Pahrump. And I'm not saying worse because Pahrump is bad. Pahrump is not bad. It's just the drive out to Pahrump that's kind of bad, right? That's a pretty oof drive. Or Needles. Boulder City's not too bad, yeah. But Needles, yeah. I once had a home health agency like, so we have a patient that we need seen for home health. They're in a suburb of Las Vegas. I'm like, oh, is it Pahrump? Is it Boulder City? And they're like, no, it's this place called Tonopah. That's not a suburb of Las Vegas. Yeah. You better be paying me to drive to Tonopah. I'm just saying. Actually, I had one there before on YZX Road. Yeah, that was fantastic. So on the road, not actually, it was literally in a place in the middle of nowhere. You may get some on Mount Charleston. Those are some of my favorite ones to go to just because I love that drive up there. That is just, I'll almost take them for no extra money because I like to drive up that way. It's just such a nice, beautiful drive, and I'm okay with it. Although parking can be a real pain in the butt, especially during winter. Like finding any parking to see a patient up there is pretty much impossible. But so you set up your zips, and then you're going to negotiate your rate. And we'll talk about specifics about rate in a little bit, but most pay you based on the appointment. So you'll get a flat rate for each appointment. Some will incentivize you based upon the distance you travel. So maybe if you go to Pahrump, you might get an extra $5 or $10 an hour, right? So that's the way they kind of reimburse you. This is the problem that most people don't take into account is you are not an employee of the company, right? You're a 1099 contractor. That means they are not taking taxes out of your money. If you see 5 patients and it's $50 a visit, you're getting a $250 paycheck. That means you need to manage your own taxes, and that can be really difficult for people. Now, if you're a person that has their own business on the side, like I know Kelly has her own business, it may not be that bad for you because you've already got you got the idea of managing money like that. But for most people, managing taxes is a totally different world. Like, I don't know what I need to put back. I always felt a good rule of thumb is to put 30 to 35% of my paycheck back and away. So if I have, a $200 paycheck, I put $70 of it in my tax account. And then if I have too much, and it just went up exactly, right? If I have too much in my tax account, great. Then I have a little bit extra at the end of the year. If I have too little, that's the problem. Like I ended up with too little this year. So I owe some money into the federal government this year. It's really hard to gauge it. It seems like every year, like one year I'll do it really well and I'll pay, like maybe have a $5 in owed tax or I'll get a $5 refund. And then the next year I owe like $2,000. I don't know. It's just really kind of wonky sometimes with the tax code. And make quarterly payments. That was gonna be my next thing. Make quarterly payments on your taxes makes it easier. It does. So you're gonna have to manage your own money. Now don't get me wrong. Some home health agencies may make you an employee and you'll get paid a flat salary, a flat paycheck every week, like a normal thing, but it's pretty rare. Ladies, right? Safety wise, I know this is a concern for you, for most of you, right? And even guys, honestly, but I know this is not being sexist, and I'm not saying that ladies cannot take care of themselves. Please don't say that. I'm just saying that it can be kind of scary, right? Especially if you're not somebody that's used to traveling to other people's homes. It can be uncomfortable. And that's the other thing you have to get used to. So it depends upon your agency. That's a really good question. So Kelly asked, can you carry? There's not a specific Las Vegas or Nevada statute on it, if that makes sense. So it's not like there's nothing that says healthcare providers cannot conceal carry. So it depends upon your agency. If you're intending on doing that, you better make sure that you check with them before you do, because that'll get you fired quicker than anything. And also, if you are somebody that is going to carry, even if you are going to open carry, you better get a concealed carry permit because Las Vegas Metro doesn't play around. Right. And that's what I was going to get at. So, here's the deal. So if you're like, maybe, I'm just going to use Kaylee because she just responded here. This is not actually an attack on Kaylee. If Kaylee says, look, I don't want to go to the ABCD streets and I don't want to go to Martin Luther King Boulevard. Right. Then the home health agency is going to say, okay, I'm not going to send you there. And who are they going to send? They're going to send me because I'm like, yeah, fine. I'll go there. I don't care. I'll do what I want. There are some specific areas in Vegas. I have a strange amount of women's story. Yeah. There's some specific areas of Vegas that are more uncomfortable, right? I just mentioned the alphabet streets, right? The alphabet streets are not the best part of town. Just north of the Stratosphere, another not the best part of town, right? Up and around the not the airport, but the Air Force Base, not the best part of town. Anything on Boulder City Highway, not the best part of town. Now, that doesn't mean if you live there, you're a bad person and blah, blah, blah. It's just those are some areas that are some of the, more sketch areas is what I call them. Although it's funny, I'm finding that now Henderson's getting more and more sketch as well, a little bit. Not in the terms of Henderson's a different type of sketch. Henderson is the hoarder sketch. So, so you've got this safety issue. You have to be thinking about yourself. I highly recommend, and I'm working on one right now. I'm putting together a healthcare provider's self-defense course, where I'm going to probably instruct, and I may just offer it free to PIMA patients, or not PIMA patients, PIMA students, where it just teaches you basic self-defense. It's not going to teach you how to do a jumping, spinning back kick, but it'll teach you the basic ways to get out of situations you don't want to be in. That usually works out really well, Kelly. Throat punch works well. Eye gouges work really well too. But just some basic stuff. I've been working on this for about probably a year and a half, and I go back to it and I work on it. I just got to get it finished and stop being procrastinated. Procrastinators unite tomorrow. So you've got the kind of the areas you don't want to work in. And then there are some areas, like I've had PTs and PTAs to say, I don't want to work in my own zip code. Like I don't want to work, like I live at 81119, 89119. I don't want to work in this zip code because I know my neighbors. That kind of makes sense, right? You don't want your neighbors as your patients, especially if you know your neighbors and you're like, I don't care. My neighbors don't care about me other than dropping stuff on my hands. But some people just don't want to work on their neighbors, right? So it is what it is. So that's kind of that nutshell. The other thing you have to deal with is people's homes, because you're going to be going into people's homes. It's pretty rare that you meet them someplace else. Like sometimes I have had some patients where I'll meet down at Sunset Park? Is that what it's called? I think that's the park down south of Pecos, right? That big park down there. I like meeting patients at the park because it gives me a lot of options to work on them with, right? I can walk, we can do grass to gravel transfers. We can go over and we can practice like shooting hoops while I hold on to them in the wheelchair and stuff like that. So there's a lot of stuff that I can convert into home health. The big thing with home health is you do not have all the toys. You just don't have all the toys like you would have in an outpatient clinic, right? I have a set of weights. So I have 2 crates in my truck. And this is, any PT or PTA that's ever gotten to home health, when they ask me what my recommendations are, I say get 2 of those milk crates. Milk crate 1 is all of your good weights. So this is your good cuff weights. This is your good dumbbells. Maybe you have a couple Swiss balls in there. I keep a bunch of TheraBand in there that I buy the individual packets of TheraBand. That way I can give them a piece to keep. And then usually I come back, I'm like, where's your TheraBand? And they lost it. It happens every time. And I'm out the money for it. I have a TENS unit in my bag, and I'm trying to what else I had in that box. I have a couple of different stuff that I keep in that box. And then I have the I don't care box. And the I don't care box are my sets of mismatched weights. There are a couple vinyl coated, cuff weights, stuff that I can literally take out of my truck, put on the sidewalk, and spray down with a hose. Why do I do that? Why do you think I keep 2 different sets of boxes or 2 different sets of equipment? And why would I want one that I can spray down with a hose? Yeah, people are gross. Yep. Right? If I don't want to take my good set maybe into a hoarder's house where there are insects all over it. Right? I want to have the set that I can just take and hose down. So that leads me into the next thing. Yes, you will encounter hoarders. Period. You will. You'll encounter paper hoarders, book hoarders. You'll encounter pet hoarders. And then just the general gross houses. And here's the deal. You can't walk in and go, holy crap, this is a pigsty. But can you use that as a safety hazard and talk to them about it? Absolutely. Look, this isn't safe. You can't even get out of your chair. I remember I had one where I went to the patient's house down in Henderson, and I knocked on the front door, and the patient calls me on my cell phone. He's like, I need you to go out back. There are stairs going up to the rear deck up by my bedroom. You come in through the window in my bedroom. He had that much hoarded that we couldn't even open the front door. And it was newspapers and magazines and stuff like that. That also goes to the one thing that probably freaks everybody out that goes to home health: bugs. You will go into houses that have bug problems. I've been in one house where I thought the carpet was moving. There were that many bugs in the apartment. Those are the houses that I keep a spare set of scrubs for too. So this is not to scare you. Those are the rare patients. Those are not the everyday patients, just to let you know. The everyday patients are your little Millie and your little Bobs that are just out of the hospital after a total knee replacement. And they just want you to come in and mostly, honestly, talk to them. It's pretty much you're gonna do a lot of talking. So what are the appointment times? Most home health facilities say, and this is a generalization, this is not every home health. Most home health agencies say you have to spend at least 45 minutes with every patient. So you're going to spend 45 minutes with the patient. The reason they say that is because they figure 15 minutes for travel. And you have to calculate that in. This is where some people think they're making more on home health, and then until they realize they're not. Because they're taking appointments all over town and they're not organizing their schedule. That is the biggest mistake I see of new home health people, is you don't organize your schedule. That's why I want to be in charge of scheduling my patients. Because let's say I have somebody in Pahrump. I want to make sure I schedule all of my Pahrump patients at the same time of day, so that I only have to drive out there once and I can drive back and I'm done with Pahrump. Or if I have to go to Boulder City, right? And most of the times that the home health agencies call you, they'll say, got a patient in Pahrump. But one of the things I'll say is, do you have two? I want to make it worth my while to go down there, right? Do you have anyone else that you need seen down there while we're there? Because it just makes it more worth our while to see more than one appointment. You know, it's pain in the butt if you see a patient down in Lake Las Vegas and then your next patient's up in Mount Charleston. You have to calculate that in. You're going to spend a lot of time driving. And this is Las Vegas. Traffic sucks. Doesn't matter what time of day it is, right? You could be seeing somebody at 4 o'clock in the morning and end up a traffic jam on 15 because somebody looked at a sign wrong, or one of the strip clubs had too much of a flashing light and it caused somebody to have a seizure and wreck. So any time of day, this weird stuff can happen. What kind of patients will you get? You'll get every gamut of patient. You'll get, your Medicare patients and Medicaid patients that are low income, maybe, all the way up to, going down to Southern Hills and working with patients that are right next door to Mike Tyson. Just watch out for his tigers. I've had all walks of life of patients in home health. It's one of the few areas where I can say that it's not specific, that you're going to see this type. So that's one way you can do home health is through an agency. The other way you can do home health, and it's primarily the way I do home health, is I sign up under PTs. So I know a lot of PTs in the area that do home health, and they'll call me with specific cases. Especially like, I have a really good friend who's a really small kind of petite female PT. She'll go and do the evaluations in the bad areas, but she won't treat. So she'll call me up and say, hey, I've got a patient here and here's the rate. And she pays me, not the agency. So she'll get the payment for the agency for her. She'll take her stipend out of it and then pay me for the visit. That's completely legal as long as I have access to document on that patient. That's one of the ways home health. The other way that I've been primarily doing lately is I work for a PT that we do cash pay. So we have a flat rate for every PT appointment for the patients. The patients, when I go see them, they pay me that flat rate. I deduct my money out of that flat rate and I give Andy the other half or the other chunk of it, and it goes into the company. And it goes into getting marketing and get more patients. So there are a lot of different ways home health can make. And again, the number one reason most of you guys want to get into home health is that guap, that money. You can make money. You can hustle. I mean, I know some PTAs that hustle doing home health and make over 100K. It's not unheard of, but the PTAs that I know that are making that are seriously hustling. They're seeing 8 to 10 patients a day. They're going all over the city. They're taking the patients in the areas that most people won't take them, right? They're really kind of hustling. So it's a good way that you can, make up some of the student loans and stuff like that. They're poor cars. And that's the other thing I was going to say is actually, one of the things I did when I got a home health job was I bought a cheap car. My little Versa that I have is my home health car. Yeah. Because, now my Versa is kind of nice. It's got some creature comforts in that, but let's face it, if somebody's going down the road looking for a car to steal, the Versa is not one they're looking to steal it. Encompass does offer a car if you're full-time, but again, that'd be one of those rare cases where you're actually getting paid on a salary as well. So that's kind of a nice both ways around, right? And Encompass is a double-edged sword for me, but I'm not going to get into that. I don't want to open that can of worms right now. Encompass is definitely a double-edged sword. But yeah, money-wise, how much have I made as a PTA on home health? Well, honestly, I've made a gamut. I've made as little as $15 a visit. Well, then you're going to say, well, why would you only take $15 a visit? What do you think would encourage me to only take $15 a visit? Knowing me, because you guys know me for a little while now. Why do you think I would only take $15 a visit? What do you think I'm probably seeing at that point? Benefits could be, yep, that'd be one thing, right? I'm probably seeing a kid, right? I'm probably seeing a kid that's in a low income area. And, here's the deal. If the kid is Medicaid or CHIP or something like that, our home health agency is going to get about $8 for the whole visit, for an hour visit. So even paying me $15, they're losing $7 on that visit, because that's how poor Medicaid reimburses. So yeah, I mean, I've taken as low as that. If I know that it's a kid that, that needs the help, especially, I had one for a while that was not Down syndrome, Duchenne's muscular dystrophy kid. That kid, for the agency I worked at, I almost took no money for them, because I literally saw him since I came into Vegas. And it wasn't that there was a benefit there for me more than just the money. It was that I had an established rapport with the kid. Right, I actually turned him over to one of the other PTAs that needed some hours, so that the PTA is seeing him now for me. So yeah, I've made as low as that. The most I've made is $75 a visit. And some of you are going, oh yeah, those are going to be the rare ones. The 75 was, up on extraterrestrial highway. So they're like, hey, we'll pay you to go see this patient, but literally get ready, because you'll get alien abducted while you're out there. So it just depends upon what you're willing to do, how much you can make. But you can make some serious money in home health. So it's a good, valid way of making it. But again, you have to be really disciplined with your schedule. Home health, I found, is really good for moms and dads that want time with their kids, because you can schedule your home health visits while the kid's in school, right? I'm going to see patients. I'm going to call my home health agency, and I'm going to see patients from, 9 o'clock until 3. And you just hustle and get those appointments in 9 to 3. I had a couple of PTs and PTAs that I saw like that. Or I had a couple where they would see patients from 6 to 10 at night, because the other spouse is home at 6 to 10 at night, right? So there are a bunch of different ways. And I'm not judging parents. I'm just saying that literally I see a lot of that when I'm in home health. They want some more time with their kids. It's an easy way to make some money and still spend time with your kids. The downside to home health, there's no vacation. If I'm only working home health and I take time off, guess what? I don't make any money. So one of the things I do, and that's why I keep my licenses in some of the states, like back in Pennsylvania when I'm there, is because sometimes I'll call up the places I worked in Pennsylvania and say, hey, I'm coming back for, a week in December. I'll be in for the weekend. Do you need any help at the hospital on the weekend, PRN? And I'll make a little money while I'm back there to help cover my visit. But for the most part, if you take time off when you're working home health, there's no money coming in. It's pretty rare. Some of the home health, like Encompass does, because it's full time, they do give you a vacation and stuff like that. But most of the home health agencies, you don't get anything. It's just the way it is. So that's kind of the gamut of working home health. Now, what are the downsides to working home health? Schedule is number one. Some people just don't want to schedule patients themselves. That's just the, if you don't want to call patients, you don't want to make that, and home health is maybe not your goal. If you can't organize and you have no ability to keep your own schedule, if you know that even getting up early and making sure you're here on time for school is a struggle, home health might be a struggle for you. You just have to figure out if it's something you want to do. It's going to take you a lot of practice to get a good schedule down. We talked about the kind of weird people that you might have to see. The other thing is intermittent work. What I find with home health is I have peaks and valleys. I have a time where I have like too many patients and then it'll die off. And I'll have no patients. And then I have too many patients. It's not like a nice, even kind of keel. You can even that out by being with multiple agencies. But it does get rough at times where you're like, I have no money. I'm not getting enough. I got to hustle, right? So that's when maybe have to keep PRN at a hospital or PRN in an outpatient clinic, where you can pick up a few extra bucks here and there if your home health is low. It's just kind of a very big balancing act with home health. It's not something that everyone can do. Some people really enjoy it. Some people hate it. I have found that most of the people that I've seen in home health are people that have been able to do outpatient. For whatever reason, when I see inpatient people going home health, that just it's not as, they don't enjoy it as much. Because, honestly, like I love inpatient acute care. I just really do. It's fantastic. Home health isn't the same. Right? Home health, you're basically doing heel slides, knee extension, or quad sets, stuff like that all day long, every day, 20 patients. It gets old really quick because you can't do much, right? You may have some workers' comp patients while you're out there as well. So you have to be aware that you may have some PI patients, personal injury patients while you're out there. You have to pay attention to that. What are some other downsides? So some other downsides are inappropriate comments and inappropriate advances. And this is not limited to females here, because usually males are the ones that kind of get the bad rap for making inappropriate things. Females are just as bad for guys and for girls and guys and all the way around. Let's just go there anymore. For me working with pediatrics, we get a lot of transference, where single parents may be seeing see you work with their kid, and you're paying so much attention to the kid, and oh my God, you care about the kid so much, and all of a sudden it develops into an infatuation, which is kind of awkward. Little old ladies and little old guys make inappropriate comments all day long when you're in home health. It's just kind of that, and you have to understand what you're willing to take and what you're not willing to take, and set your boundaries. If somebody's saying something that's inappropriate, tell them. Right? I had a little old lady once that every time we did an exercise, she wanted to smack my butt. Like, that is not appropriate. No. Oh, I'm just playing around here. No, off limits. No touchy. So people can be a little weird, is what I'm saying. What happens if, even if it's an inpatient or outpatient, what happens if you're in a situation that you're uncomfortable with? Tell the patient flat out, I am uncomfortable with this. Let them know, set your boundaries, because if you don't set your boundaries, what does that tell them? Yeah, you can. It's not necessarily that you consent. It's okay to keep doing it, right? I don't like to think consent, because you're not really consenting. You're just not saying anything, right? It's kind of the same idea that, you're out at the bar and somebody walks up to you and says, oh, let me buy you a drink? And you're like, no, you're not buying me a drink. That's okay. And 15 minutes later, they come up to you and like, I was over at the bar and I was already over there, and I figured I'll get you this drink even while I'm over there. And you take that drink. What you've just told them is you've acquiesced that was okay. right? Same thing here, telling them, no, stop. And I'll say, look, we either stop this or I'm going to have to stop the therapy session. And I will document this. Usually if you say I will document this, that usually puts a stopper to it really quick. I've had more uncomfortable incidents doing private inpatient or private care. And I think, what was I going to say? Oh my God, my brain just completely and utterly. Oh, I know what I was going to say. No, it depends. I'll answer that in a second. Like Tyler can probably attest to this as well, because I think Tyler's the other LMT here, is that I've had more inappropriate patients in massage therapy than I've had in, he doesn't do PTA, but I've had more inappropriate in massage therapy than I've had in PT, to be 100% honest. And especially if I'm doing like private care where I'm going to people's homes for massage, that seems to get awkward really quick, especially because it's Vegas. But yeah, so Anthony asked, do they not want to work with you after that? It depends. So I've had some patients where, you know, yeah, they're done with me. They'll call the home health agency and say, I don't want to work with Keith anymore. And you know what I feel about that one? Good. If you don't want to work with me, I'm okay with it. So another question I get is, well, can I record my sessions? Because maybe you want to make sure that you are covered, right? And I've thought about that a lot sometimes, like, and I don't know if Tyler's ever had this thought with massage. I've thought about that a lot with massage going, man, do I need to have an audio recording sometimes just to make sure that I don't get in trouble, you know, with whatever they're doing and stuff like that? I thought of that. I don't know if he's ever thought it or not, but just one of those where I'm like, man, is this one of those? And so I would not recommend ever record. First of all, you can't record without consent. But on top of that, it's just, you know, if you're really that worried about the patient, maybe it's time to think about a different patient. It can get frustrating. It can get kind of stressed out, but you can, like I said, you can make some money. Especially if you're one of those people that are go-getters and willing to work with whatever PT. It's funny, I have two different types of PTs that I work with in home health. So I have the PT, I encountered the PT that basically just throws every single patient at me and says, good luck, figure it out. Right. And that's the other thing with home health, you are not going to have a detailed plan of care, meaning you're not going to have a flow sheet. Very rarely do PTs that are out in home health make a flow sheet. That means you have to be really good at reading the eval and making exercises and activities that are appropriate for the goals that are set. You know, so I have some PTs that are just like, you know, I've got a patient in Pahrump, I've got a patient in here, I've got a patient in here, and they just toss me appointments. And then I've had the other PTs that won't toss me appointments until I've met with them. You know, so they kind of screen me. So I've got to go to not Costco, but I've got to go to Starbucks, and we've got to sit down, and they've got to talk to me about what my abilities are. What do I know how to do? How do I know how to treat? And I kind of like that a little bit, as long as they're not like totalitarian and are going to tell me everything I do. But it is kind of nice sometimes to have a PT because that tells me they're actually invested in you, right? Ultimately, it doesn't matter how you get the patient. Remember that the PT that is the PT of record is responsible for that patient. So whatever you do is back on them. That brings me to one other thing. Making sure that when you're out in the home health field, you have adequate supervision. Because this is one of the areas that I've seen that home health agencies are not very good at, where they'll assign one PT, 5 PTAs. Now, most times, if you get an audit, there's a way to say, well, you know, I was working while the other 3 PTAs weren't or whatever. Usually you're pretty covered there. But I mean, if the one PT's got 5 PTAs working full time for them, they can't supervise all 5 of them. So you have to make sure you're within your supervision ratio. Do you guys remember what the supervision ratio is here in Las Vegas? Because this is actually part of your Okay, 1 to 3, right? Okay, and so 1 to 3 is right. What's the one caveat to that? So there's a caveat on that. Yeah, so 1 to 3 with no more than 2 of the same discipline. So what that means is they can have 1 tech and 2 PTAs, 2 techs and 1 PTA. That is going up. That's another thing that's in the laws. It's written, it's ready to go. It's just for whatever reason taken for a while. And we're going to add 1 along those in order to add for a student, which is going to really free up our educational system where they can take a student and it won't count against their PTA count. Typically in home health, you can't take students. Why can't you take students in home health? What does taking a student require as a PTA? So if you want to take students, right? Well, liability is part of it, yeah. But yeah, it requires direct supervision of a PT, right? Because the PT is ultimately responsible for that student. Now that doesn't mean that you can't go on home health visits. But really, if you, now I'm not gonna ask if any of you went on home health visits or anything like that, because I don't want to know. But really, if you go on a home health visit, you really should only be with a PT, because that's the only way they can directly supervise you. Or you just go for observation and it doesn't count as treatment hours. I've had a lot of students that want to go on home health with me. Like I've had some of you guys where students are like, was there any way that, it's funny. I remember from cohort 5, I think it was, one of the students was like, I really want to go with Mr. McKeever because I was doing full-time home health and teaching. And I'm like, no, you don't. You don't want to go see patients at 2 o'clock in the morning. Like, you don't want me to call you all day long and say, okay, so at 2 o'clock, we're going here. Then we don't have another patient till 5. And then from 5 to 9, we work hard. And then we have about an hour break. And then we go see some. No one wants to do that. No one wants my crazy schedule. Plus, just imagine, like, you guys don't like me as an instructor. Just imagine how much fun it would be as a CI. I'm a terrible CI. What other questions can I answer about home health? I can have fun sometimes. I'm joking. It's a little self-deprivation here, or it's a deprecation. You're not deprivation. I'm not depriving myself of humor. What other questions might you have about home health? And nothing's out of bounds, so ask whatever you want. I'm not saving the chat, so you can ask. I'm not going to save that. And if there's something odd that's get asked, then I won't state your name. But is there anything that you can think of? Paperwork. Okay, good question. So as long as your home health agency is compliant with Medicare, you'll have electronic paperwork, electronic health records, just like anything else. I believe, and I have to look at this, but I'm pretty sure that the Medicare rules are you have to have the documentation in within 7 days, which I think is kind of stupid, but I believe Nevada has now set it that you have 48 hours to get your paperwork in. I believe they changed that recently. So you have basically 2 days to get your notes in. Most of the time, you're not going to want to do that. This is probably the downside to home health, is that a lot of times when I'm doing, around the town, my electronic health record is web-based. So that means I have to have a 5G hotspot, or not 5G, but I have to have a hotspot with me in order to, get on my laptop, put my notes in, stuff like that. I find I do a lot of my notes while I'm waiting for a patient to get home. So maybe I had a patient at 10 o'clock in the morning. My next patient's at 12:30 and they're up in Centennial Hills. So I'll drive up to outside the patient's house and I'll start getting my documentation done for the past couple of visits. I try to do that because I don't like taking stuff home. I love my computer set up here, but I want to play video games. I don't want to sit and do paperwork. It's just not something I enjoy. But a lot of PTs and PTAs will wait till the end of the day to do all of their documentation. And then there's, so they made $45 a visit, but now they're sitting for 4 hours at the end of the night doing documentation. And when you average it out, they're making less than they would have made at home health or at outpatient. Most clinics or most of the home health agencies I worked at use Web PT. So Web PT is just a web-based EMR. It's pretty simple. Some of them use Cerner. Pretty rare that I use Cerner. It's the other one. There's one other one that's pretty common nowadays. But it's just like any other EMR. So it's not that different. I did have one home health agency that required, that did paper documentation. And that was a bit of a pain in the butt, even though it was supposed to be electronic. They wanted you to document on paper and then they scanned it into the patient's record. So you had to write out, and they wanted narrative notes, which everyone loves narrative soap notes. Everyone loves them. And so, I had to sit there and write a book for every patient that I saw. The paperwork's not bad. I mean, it's no different than outpatient or inpatient, honestly. As long as you can, again, manage your time, right? So you got to think about that. If you go see a patient for 45 minutes, you have 15 minutes of travel, you probably have another 7 or 8 minutes worth of documentation for that patient. And I don't recommend documenting while you're driving down the 15. Don't do that. Anything else? Any other questions? Anything else you guys can think of that would hit you with home health? How many of you guys are actually interested in home health? I know Kelly is, because she's been all about that. So Anthony is, Emily. Okay, so a good bit of you. You can also do home health in conjunction with working in an inpatient setting or working outpatient. The one thing I'll say with that is make sure you talk to your supervisor before you do that. I worked for a clinic here in town where I wasn't allowed to see home health pediatric patients as long as I was working outpatient pediatrics at this clinic, because he felt that if I did that, I was actually taking clients away from him. And what he didn't realize is a lot of times, guess what happened to those home health patients? They funneled right back into that outpatient clinic because they had established rapport with me at the home health agency. Why wouldn't you come over and work with me at outpatient then, right? Especially with kids, and with some of the kids, again, I get along with kids because we're on the same mental wavelength. What else? Anything that you guys can think of? Nothing else? That's it. Usually I get bombarded with questions. Also, you can be on home health attached to the hospital. Summerlin has a couple of home health staff as well. So some of the hospitals, I think Mountain View did. I don't know if they do anymore. But some of the hospitals still do have attached home health. And even if you're in some of the hospitals like, excuse me, Kaylee mentioned Encompass. Encompass has home health, but they also have their rehab therapists do home visits to do like safety inspections and stuff like that, which is also something you do for home health, where you go to the patient's home and you do a safety assessment. You go, okay, we got to get rid of Fido. We've got to get rid of these throw rugs. We need a ramp and all that fun stuff too, which those visits are a little bit fun. Oh, wound care. There's the one that no one asked about, actually. Can we do wound care on home health? Absolutely. For sure. If you're in a home health agency that does that, now most wound care is done by nursing in home health, but there are some that once they find out that the PT or you do wound care, they're absolutely all about it. Like they'll send you in to do wound care and go out and do it. The downside to that is you have to make sure you have all the supplies before you go. It's not like you can get out there and MacGyver a wound care. You got to make sure you have everything before you go out there, which means you have to have a pretty stocked wound care kit. I know one PT in town that specifically does, that's all he does for home health is just, he does pressure injury wound care. Literally, that's all he does. All of his patients are just pressure injury wound care. And he sees them at home. Right now, yes. So Hector asked the whole 2,000 hours things, do you have to have those before you enter home health? Right now you do. That is changing. And again, I've been saying that is changing for about a year now. I'm getting a little frustrated saying it. It should just change. I don't know what the hang up is. We've got everything approved. We've got all the legislation passed. I don't know why those changes aren't going into effect. I stopped getting kind of involved in the politics of it. And I think I probably need to get a little bit involved again and see why the changes aren't going into effect. But yeah, that's going to eventually be completely gone. That 2,000 hours, which is going to free up a lot of things. It's going to free up a little bit of outpatient as well, right? Because one of the problems at outpatient right now, and I had this at a PTA that I had a problem with this at, the PTA didn't have 2,000 hours. I have my 2,000 hours. I've had it since, dinosaurs roamed the earth. So I could manage the clinic by myself. I could be the only one in the clinic and treat patients and blah, blah, blah. But that PTA couldn't be in there with me because I didn't have supervision. Nope. Yeah. So if the law is stricken from the books, the law is stricken from the books, period. Out, gone. And there's some legal justification as to why it's going away. And I don't want to bore you with the whole legalese of it. I was actually in on the court case for this. I just don't know why it's taking so long. You guys will find out. I know some of you are a little bit older and some of you are kind of like, Jaira, who's just a little green behind the ears and a young little pup, but you'll find, or Alexa, right? Some of you guys are a little young behind the ears. You'll find quickly that politics seems to take forever. Getting anything changed at the political level takes a monumental move of a mountain. So that depends. So Anthony asked, do patients perform basic exercises? This is a great question. And how many exercises on average you perform? It depends. I really want as much as I possibly can get done in that session. So I know some PTs and some PTAs kind of drag it out. I've known them. I know those clinicians that are like, okay, let's do 5 of these. And then they're like, talk for 5 minutes. Okay, let's do 5 more of these. I really do try to cram them in. So my typical session when I'm out at a home health visit is I do about 10 minutes of a warm-up. And I vary. It may be, I have an exercise bike, one of those little ergometers, and you can pick those up for like $25 at Savers. So I take one of those with me. I have them warm up on the exercise bike, or maybe, again, I showed some of you, you can do an exercise bike with a towel, just by using a towel. I maybe have them do some sit to stands, just kind of warming up. So I do about 10 minutes of kind of a warm up. And then I do all of my manual therapy. So I'll do all my stretching, all my myofascial release, anything I have to do on that patient to kind of loosen up the tissue. Probably about another 10 minutes of that. And then about 23 minutes of exercise. Gee, I wonder why I picked 23 minutes of exercise. Well, that's 2 units, right? I'm still stuck in that mindset from everywhere else, right? So I do about 23 minutes of exercises. I usually in the home health setting will do reps of 5 to 7, just because usually the patient's very deconditioned. So I would rather do a higher amount of sets and a lower amount of reps with those patients, just to kind of build up their endurance a little bit for outpatient. Maybe a little bit of gait. I may not have all Therax. I may have, 10 minutes of Therax and 10 minutes of gait or something to that effect, depending upon what my goals are. I may do stairs. And then I have about another 5 or 10 minutes at the end of reviewing their home exercise program every visit. Okay, let's talk about your HEP. What are your exercises you're going to do? Okay, how often are you supposed to do these? Let's review that active cycle of breathing real quick. Do you remember if you get short of breath, right? Because most of our job is going to be education while we're out there and getting them ready to go to home health or go to outpatient. So does that kind of give you an idea of kind of what I do in a 45-minute session? Now here's the deal. If I have a patient that can do 45 minutes of Therax, guess what? We're going to do 45 minutes of Therax. I'm going to tell him, okay, I'm going to be there at 8:30 today. I need you to warm up before I get there. Get up and walk around your house a little bit, get your muscles loosened up, maybe get a hot shower, right? And get ready for me because I'm coming, baby. And we're going to do 45 minutes of hardcore, P90X. Get ready. And some of the patients love that. Like the Marine I was telling you about down at down at Lake Las Vegas. Absolutely loved that. He would get up and he had a little exercise bike in his house. He'd get up and get 15 minutes on that as soon as he get up. Then I'd come see him. And man, I would just be brutal with him with exercises. And he absolutely loved it. Yeah, and then the PT is going to discharge soon after. Yeah. The only reason I saw that guy down there for so long is because he was paying cash pay. He wanted the PTA to come out to his house. He didn't want to go to an inpatient clinic or an outpatient clinic. But yeah, so that's this is the major problem. This is one of the major problems I see with the home health agencies is home health agencies want you to keep the patient on caseload as long as you possibly can. Realistically, think about this, and you don't know that much about home health, but think logically about this. How long do you think that a patient should be seen in a home health setting? Let's see how close you get to what I feel is. What do you think? Yeah. So Emily says 12 weeks. Hector says 2 weeks. Michelle says 1 to 2 weeks. Yeah. So I usually go, I mean, maximum of 10 visits, 6 to 8 visits is about what I max out at. So it depends upon how I do it, because my goal is not to see them forever. Most home health agencies, Emily, want that 12 weeks. They would love that because that's cheddar coming in. Ooh, right? And I sometimes butt heads with my home health agency and say, hey, look, this dude needs, you know, he needs IFC. He needs ultrasound. I can't do that. They need to go to outpatient. What's a good rule of thumb when they're ready to go to outpatient? What do you think? Not time-wise, but what would be a good, what could you set as a goal, you would think as a goal before they're ready to go to outpatient? Yeah, they can drive. Yep. Right. I think we had didn't we have a scenario with that on the, when we met with UNLV? Right. If the patient can drive for the most part, they should be going to outpatient. And some insurance carriers won't approve home health if they find out they're able to drive, because home health is more expensive. So let's say if the patient can drive, they should be going to outpatient. And sometimes it's not even driving. Sometimes it's just educating, because maybe they don't know about Ubers or Lyft. You would think, here's the deal. You would think everybody in the world knows about Uber and Lyft. You would think. They don't. You show them they can get a ride from their house to the clinic and the clinic to their house, and you explain why it's better to go to outpatient, because they do have all the toys. A lot of them will go to it. That comes to a question about the end. Can we recommend PT clinics? Like, say maybe, so what would be the only restriction do you think about recommending PT clinics for the most part? You can't really tell them to go to your PT clinic. And I never did that with any of the pediatric patients I had. Most of them didn't even know what outpatient clinic I worked at. Right? It's not good form if you're working in an outpatient clinic and a home health agency to try to steal the patient from home health to move them to outpatient. Right? But I mean, the other downside to that is you also can't, they say, you know, I want to go to grind the meat wheel physical therapy. Right? You can't say, oh God, man, they see so many patients. You're not going to get quality care. You've got to be real careful what you say. You know, if this patient asks me, well, where do I go for outpatient? I'll say, well, there's plenty of places in town. There's Select Physical Therapy. There's Affiliated. There's Edwin Suarez Physical Therapy. There's ATI. There's all kinds of places out there that you can get it. What you really should do is look at your insurance and see who's approved. Now, some of the home health agencies will contract with outpatient. A lot of them contract with Select, where it'll be a feeder for Select. So, you know, they get done with home health and they go right into Select's physical therapy at the outpatient level. It's okay. If your home health agency contracts with them, that's okay. We just can't be kind of greedy and try to steal patients. Wow, that took longer than I thought. I guess I rambled too much. Anything else? Was this informative? Did this give you guys at least a kind of a window into it? I really love home health. I really do. Did I scare anybody about home health? Okay, good. Yeah, I mean, it's not, yeah, only the hoarding. It makes me more interested, right? Yeah. The hoarding can be kind of terrifying. I'm going to be honest. The worst, the only fear, right? And that's kind of that's one of my paranoias as it is, right? I only have the worst hoarding I had was the lady that hoarded animals and including dead animals. That was the worst hoard I had. Now, that actually brings one more thing up. Reporting. Once you have your license, do you know what you are called at that point in healthcare? There's a specific term for us. Professional. Okay, yeah, that's two. Hopefully you're professional. You're a mandated reporter. What does that mean? If you see something, you have to say something. Report dead animals, yeah. You know, so that literally means you're a mandated reporter. If you go to somebody's house and you realize they're abusing an old person, you have to report it. If you go to somebody's house and you realize they're abusing a kid, you have to report it. I've had some really bad situations with that before. But you are, what happens? So what happens? You're working with a patient named Bob. You know, Bob is a vet and he's living alone now. He lost his job and he's really stressed out. And Bob's throughout the whole sessions dropping hints that, you know, sometimes the world would just be better off without me, and blah, 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 blah. Should you report that? Yeah. Right. You maybe, call police and report. Yeah, report it. I would first call my PT just to make sure, like, hey, I get really concerned about reporting. So the first person I usually call is my PT unless it's an imminent danger. I did have an imminent danger with kids once before, and that I reported immediately. I walked right out of the home. I called the police and I told the police I wasn't leaving until they got there. And I don't know about you guys, but I'm kind of a scary person. So that person wasn't going anywhere. But yeah, you're a mandated reporter. So please think about that when you're out there. This also applies at inpatient and outpatient. Yeah. Kid with the burns. Yep. So it's just one of those that you're a mandated reporter now. You see elderly abuse, you got to report it. What about drug abuse? That's a really tight rope, right? You go in and you see if you're going in and you're treating the patient and you notice over in the corner, you see that they've cut their breakfast on the mirror. And, you know, all right, some of you got it. Is that something you report to the police? I struggle with that one. If they're in a life-threatening condition, yeah, that's going to be one that I report. That's going to be definitely one that I report to my PT and the maybe a home health agency. Hey, you know, I'm just saying I saw Bob and man, Bob's doing coke. Yeah, maybe just be careful. Some of them don't even want to talk about it. Right. So it depends. Alcoholism's another one. Right. So you got to be careful with that. But at the same time, you can be the person that saves that person's life. So take it. I had one patient once that was hooked on synthetic fentanyl. And, you know, I reported and lucky enough, they sent a social worker out to work to see him. And the day they went out to see him, he had overdosed. You know, social worker had Narcan with them and was able to save the patient. But yeah, so I don't know. That's one of the ones to be careful. It depends on the volume. Yeah. If you're seeing that they're cutting, you know, whole snow mountains, maybe it's time to report them. But that includes like weed. You've got to be careful with that nowadays. I do not let patients smoke in my proximity. Even if it's vaping, I do not let them do it. I will tell them flat out, I will leave. Yep, we're going to take a break now. That's what I'm going to end.